questions. If you have any vaccine questions, Delta questions on COVID, we are happy to do an update next week. You just let us know about that.
Right, there've been a lot of antibiotic use, and in general, and then also related with COVID. And I think discussing COVID again would be in relationship to antibiotics would also be a good topic. But urinary tract infections, we're seeing a lot of highly resistant organisms, and I think this is a great topic to discuss.
So the talk today, we'll talk about pathogenesis of UTI in male and female, diagnosis and therapy. Also, some of the complicated urinary tract infections like pyelonephritis, asymptomatic bacteriuria, and prostatitis as well. So we'll get into very detailed.
So classification and epidemiology. So cystitis, essentially a bladder infection, a lower urinary tract infection, pyelonephritis, an upper UTI, and symptoms occur in 20% of women each year. So urinary tract infections are one of the most common infections. So that's a great reason to discuss it, because it really leads to a lot of antibiotics just in general. And 8.6 million office visits annually. And half of all women have had at least one by age 32. And it's very expensive.
Yeah, we spend a lot of money, and it makes sense because we see a lot of urinary tract infection outpatient, inpatient, we treat it, and then complications from it. So a lot of cost, but it's interesting to know that at least half of the women by age 32 have a UTI. Here, it talks about when you have pain on urination. And how do you classify this? What causes pain on urination, especially for females? So about pain on urination, bacterial cystitis, so infection in your bladder, it's about 60 to 70% of the time. But then there's other reasons why we get pain on urination as well, which is bacterial cystitis with subclinical pyelonephritis, it's a small percent. STDs, STIs, so sexually transmitted infections, and then also vaginitis. So candida infection in the vaginal area can cause excoriation in the external skin. So when you urinate, it can burn. And then there are other poorly understood cases as well. And especially in elderly women too, when estrogen starts going away, their external vaginal area can get irritated and sometimes be painful. So there are other reasons why you could have pain on urination, but when it comes to urinary tract infection with bladder infection, it's about like 60 to 70%.
Yeah, so generally, if a patient has dysuria, I will suspect a urinary tract infection. And if I do a UA and there isn't pyuria, so there aren't a lot of WECs, and then with a culture, nothing really grows, I will start to suspect other things. Is that kind of your?
Yeah.
I think you get the history and physical, and if it's not quite clear, but there's dysuria and you're thinking UTI, that's usually where I go first. And then if the UA and culture doesn't really fit, then I start, what else could this be?
I think that's why it's also important to do like exam and ask like thorough questions. Especially in our elderly females who have like this vaginitis because of like vaginal irritation because of the lack of estrogen too. So those things are important to kind of differentiate. So pathophysiology. So why do females get a lot of urinary tract infections, right? So the colon flora, like E. coli and Coccus, all these bacteria that's in our colon, it just colonizes that genital urinary area with colonization with this bacteria. So then it's easy for the bacteria to then get into the bladder and cause infection.
Right, and it's okay to have, there's asymptomatic bacteria. So it's okay to have something like E. coli in the urine if a person is asymptomatic and doesn't have any symptoms. And so just like the colon has normal flora, the bladder, you can have normal flora like E. coli, that's not causing any problems, that's okay. And the thought is that that's kind of colonizing the area. And so if something bad tried to land there, it won't be able to start to grow because there's already so much essentially good flora there in its place. The same with our skin, the same with our GI tract.
The interesting thing, we'll talk a little bit more about asymptomatic bacteria, but as we get older, there's more and more of us who are colonized with bacteria. So, how does bacteria get into the bladder, right? So sometimes it attaches to the cells in the urethral area. And some of the bacteria are really pathogenic and they could get in there. But third reason for females is also vaginal intercourse can also move up some of these bacteria into the bladder area. Risk factor for multiple infections in female, variability of the bacteria, sometimes external things like diaphragm use, not voiding after intercourse. Some comorbidities can put us at high risk too, like diabetes. So some stuff to think about as far as multiple infections recurrence. So I like this. It kind of talks about when you have cystitis, bladder infection, what are the most common symptoms? So you get urgency. So you feel like you gotta go pee. Frequency, you pee a lot, every 10, every 15 minutes. Dysuria, you have pain with urination. So those are the top 3 that we see, but then you can also see.
Yeah, and those are the most important: the urgency, frequency, dysuria. And then here it says fever usually implies upper tract disease, so that would be like pyelonephritis. You usually don't see fever with just a straight urinary tract infection. So, if I see fever, I start suspecting other things rather than just a straightforward urinary tract infection. And also, what isn't on here also is confusion. So confusion, the more and more people are saying that confusion is not related to a urinary tract infection, even in an elderly population. So I just wanted to make sure that people see what's not on here as well.
Yeah. So when you see, I like what you're saying about fever not being associated with cystitis. So if it's just the infection in the bladder, probably not going to see fever. But if the bladder infection starts going up, right, mm-hmm. going up into the kidneys, then you'll start seeing fever. So then you have pyelonephritis, subclinical pyelonephritis, but just bladder infection, low likelihood to have fevers. And I also like this, what they're saying is probabilities. So greater than 90%, you most likely have a UTI if you have pain on urination and frequency. You got to pee every 5 minutes, 10 minutes without any vaginal discharge or irritation. That gives you a good probability. So when you see a patient in the ER in clinic, if those, higher degree of suspicion, you have cystitis.
Generally, when people say they got a culture, a urinary culture, like with a urine culture, well, generally our first question will be, what are their symptoms? And sometimes people will tell us symptoms that that's not on this page. And if they tell us symptoms that are not on the page, then I start to wonder whether that was actually asymptomatic bacteria or a bladder infection. Because sometimes I'll say, what were their symptoms with this urine culture? And then, I've had people say, things that weren't very related to this. So I just want to make sure that as much as possible, we're able to identify it. Because if a patient comes in with a fever, and oftentimes people check cultures all over, which, mm-hmm. I can sometimes understand, because in the ER, so many things are happening. It's trying to understand what exactly is going on. But as much as possible, trying to ask if there's urgency, frequency, or dysuria. I think that's the best kind of course of action.
So how do you differentiate again cystitis versus vaginitis, right? Vaginitis is when there's any type of irritation on the vaginal area, but not in the bladder area. So pain external rather than internal. Fishy odor, sometimes bacterial vaginosis can have a foul smelling discharge. Candida albicans can cause white discharge and be sometimes itchy. And then also, if it's just external infection, you're not going to get white blood cells in the urine because you don't have an infection in your urine. And then also pain, some patients will have pain with intercourse, and then lack of urinary frequency or urgency because you're not going to have that type of symptoms with just external irritation in the vaginal area. So clinical cues, and how do you figure out if it's like bladder infection or if it's like sexually transmitted infection? So I think it's really important for all of us to get good history when we see a patient. And sometimes we might forget to ask like sexual history too. So it's really important to ask new partners, past history of STIs, any infection in the partner that they were worried about recently. So that will all help you kind of figure out, can this be like gonorrhea, chlamydia, some of the STI infection versus is it a urinary tract infection? What do you think, Dr. Horn?
Yeah, I think that's exactly right. Yeah, I think getting a good history is, and whenever we get a history like this, we'll always ask the family members to step out of the room. You can ask the patient kind of alone. We get kind of a better, more honest answer when it comes to that kind of stuff.
And then also, one thing to remember is because of the pandemic, a lot of the free clinics that we used to have for sexually transmitted infections, they all got closed by the state because they were focusing all their resources on COVID. So what we're noticing now is that there's a big uptick on sexually transmitted diseases, gonorrhea, chlamydia, syphilis. So I think now more than ever, it's really important to make sure we're asking and treating.
And UTI in women. So when is it a complicated urinary tract infection? So pregnancy, nosocomial, so that's hospital-acquired infections, catheter or recent instrumentation, calculi, diabetes, recent antibiotic course, structural or functional abnormalities, post-renal transplant. So these are all instances where you'd say this is a complicated urinary tract infection. And really, as far as recommendations go, for a urinary tract infection, when to get a culture, if it's just a straight urinary tract infection in an extremely healthy person, they would say that you wouldn't need to get a culture. Although, if there are no comorbidities, but I don't know that I've had a patient that has no comorbidities. So usually they have, plenty of things going on, whether it's diabetes or recent antibiotics or, other things going on. So, as far as getting cultures, through the guidelines, they'll say if it's just straightforward, you wouldn't need it, you could just treat, but that's quite rare.
Yeah. I think like in my mind, I picture it like you have a 30-year-old female comes to your clinic, they have urgency, frequency, and we'll get into a little bit later about antibiogram, and in your community, E. coli is really good with Bactrim, right? I'm just making this up. So then you tell them, take 3 days of Bactrim and then she gets better. You probably don't need culture because like she's really healthy person, right? Yeah. But if you have like somebody comes in that's 45 years old, they have comorbidity, and you should get culture because then you don't want to treat them with the wrong antibiotic and things not get better. So
yeah, I guess just in our clinics, we never see a simple urinary tract infection because they would never refer to us for simple.
Exactly.
So yeah, no, you're exactly right.
So diagnosis. So the best diagnosis physical exam wise, when you're just worried about cystitis, bladder infection, is doing a good exam, and some patients will have suprapubic tenderness, about 10% of the cases. So they'll, when you press down, they'll have pain, but not all of them do. So it's very low rate. Then you could also use in your clinic or ER, you could use urine dipstick. So you check for like leukoesterase, which white blood cells, pyuria, nitrates, reflex bacteria. There is a caveat to this though, because let's say somebody they do straight cath, they have a Foley catheter, right? They're 75-year-old with colonized with bacteria, asymptomatic bacteria, but they have no symptoms. They will have white cells in the urine. So it's always important, whatever the lab value you find, is to also then relate it back to clinical symptoms, like does the patient really have infection or not?
And I think that I would actually say that's one of the main points
Yeah.
of what you just said, because there are a lot of people that will say, oh, you have a pyuria, and therefore you have a urinary tract infection. And the patient will say, really, I don't have dysuria or frequency or urgency. I didn't know I had that. And they'll say, yes, you have one, and we're going to treat you for it. And so the best thing to do is to go to them and say, do you have symptoms? And if they say no, then you don't need antibiotics, even if they have pyuria, even if they have a lot of white cells there.
So let's say you get my urine today and we do a dipstick and there's white cells. I have no symptoms. You do not need to treat me. And it's the same principle as we get older too. And one of the big things that we always see, and I'm sure you guys see as well, is that elderly patients are coming from nursing homes. This happens a lot. They already have a lot of dementia, and then they could have an acute change in their mental status. And recent guidelines from Asymptomatic Bacteriuria, what they're encouraging everybody to do is give more fluids and try to hydrate them and see if that resolves the issue before start giving antibiotics.
Yeah, and when it comes to looking at the UA, the WBCs, they're one of the best things to look at as far as the UA goes, as far as sensitivity, but it's not very specific. So, that's what we look at. But if a patient has dysuria and they grow E. coli, they grow something you can implicate, and then they don't have very much pyuria, it's still possible to have a urinary tract infection. So in those patients that are symptomatic and they're growing something, I would still consider treating them, even though their WBCs aren't very elevated. You think? Yeah.
Agreed. I think again comes back to clinical symptoms.
Yeah, and that's one of the reasons there are so many issues with over treatment of urine. It's just the tests aren't great.
Yes.
And I feel like in infectious diseases, anytime there's a lot of confusion with things, it's because it's so hard because the tests that we have so many issues with them. If we had a better test or a more straightforward way to say this is definitely a urinary tract infection, then there wouldn't be as much confusion and issues with it for sure.
Here, what are the colony counts? So usually you want 10 to the power of 5, 100,000 colony counts. It's really interesting. I put this in here because we don't do this anymore. But apparently back in the day, they used to do bladder aspirates. Also, they to get culture.
Put a needle in. Right?
Yeah. But ideally, urinary tract infection, 10 to the power of 5. In some cases, like less than 10% of the women, you can have less colony count, but still have UTI. So again, you can't just go with one lab value. You have to look at the symptoms as well.
Right, and it's kind of they'll and this is all a spectrum, right? So even patients that have 10 to the power of 3, if they're symptomatic and growing something, I would still consider treating them. So it's not like a hard cutoff, but nothing in medicine that's really a hard cutoff. Oh, so here are the organisms for uncomplicated and complicated. And so E. coli is number 1, both uncomplicated and complicated. So E. coli would be the most common. Then in uncomplicated, you have Staph saprophyticus, Klebsiella, Proteus, Enterococci. So these things, that's essentially what you'd expect, I think.
Yeah, I think when looking at complicated or uncomplicated, I think for majority both cases, over 65 here, over 79 there, it's always going to be gram-negative,
Yeah.
Gram-negatives is your big culprit, but then you could also have some gram-positives. And if you guys see here, Staph aureus, sometimes you could have Staph aureus in your urine. Do you want to talk about it, Dr. Horn?
Sure. So Staph aureus would be an infrequent cause of urinary tract infections, but if you see it, you have to look and wonder, do they have a bacteremia? Because sometimes they'll have a bacteremia and it'll go from the blood to the kidneys to the urine, and instead of the other way around. So sometimes we'll get consults where they'll say they suspect a Staph aureus urosepsis, where it went from the urine into the blood. And although that can happen, that would be very rare. It's almost always from the blood to the urine.
So in infectious disease world, when we see Staph aureus in the urine, and they don't have a Foley catheter, they don't straight cath, they didn't have like a cystoscopy yesterday, we worry about how did the staph get into the urine, right? So we always get blood culture. We always, we might even consider getting an echocardiogram, because you really have to worry about it came from the blood into the urine. It can happen the other way around if you have like manipulation of foreign body, more likely.
We have a patient like this just recently where they had repeated urinary cultures with Staph aureus, and it happened over and over and over again until they consulted ID, and they said, "Oh, this is coming from the blood." And they checked the blood, and it was positive with Staph aureus in the blood. And so it's really good to have a high clinical suspicion for bacteremia if you're seeing Staph aureus in the urine. Okay.
So pre-treatment culture. So we touched a little bit before. So when should we get culture before we treating, right? So in complicated cases, recurrent UTI, so like if I come in with UTI and I'm back again in a month, good to get a culture, because what if the E. coli I had like a month ago is now resistant, right? So it's important to get, with complicated recurrent UTI, to get a culture even in the clinic. Pregnancy is always important to get cultures, because we know that when pregnant females get urinary tract infections, it puts the baby at high risk, it puts the mom at high risk. You could have premature birth, low weight baby. So these are all really important things. So pregnant women, when we do treat for UTIs, we should be getting culture. Males, children, we don't take care of a lot of kiddos, but kiddos, we should definitely be getting your cultures. Elderly patient, plus or minus, depending on the scenario. And then suspected upper tract. So now it's not just a bladder infection, you're worried about pyelo going up. So then you should get culture, because then you want to make sure you're treating it appropriately and you're using the right drug for the right blood for the right duration. So it's really important to get cultures in those cases.
And as far as anatomic studies, a renal ultrasound or CT, that may see something like kidney abscesses. It may see hydronephrosis, where they have an obstruction.
And one of the other big thing I always see is perinephric stranding. It's another little buzzword for like there's inflammation around your kidneys. So when you see those things, you should be thinking about upper infection.
And then indication, it says children. So children, if a child has a urinary tract infection, you're suspecting perhaps a congenital malformation or some reason why they're more prone to it than other children.
And especially in kids when they get recurrent UTI, you worry about like reflux. So like again, we don't take care of kiddos, but pediatricians have a very high tuned with this to make sure they get ultrasounds.
And then men with 1 or 2 episodes, but I mean, in men, you're thinking about anytime you see a man with urinary tract infections, you're wondering, do they have an occult prostatitis? Do they have a prostatitis that needs longer treatment besides just the 2 weeks? Or if they have an enlarged prostate that's causing obstruction, causing that urinary tract infections. And then persistent symptoms after appropriate antibiotics, prior urologic surgery, immunosuppression, or urosepsis.
The persistent symptom is really important. Sometimes you admit patients, they're kind of not doing well. You're thinking the urinary tract infection, you're treating them, but their fevers are still high. They're not responding. So if they're still in the hospital and they're not doing well after the antibiotic, please consider getting an imaging, because you don't want to miss like a stone. You don't want to miss an abscess. And this does happen, and we catch them a lot. And then if you see a stone or abscess, you got to get urology. You have to have more intervention. So it's really important to keep this in mind, and when you need to get imaging studies done.
Right, and men with recurrent episodes, also keep in mind that they can get prostate abscesses as well. So it's not just kidney abscesses, but prostate abscesses that, urology would have to go in and kind of I think of it as INDing an abscess. It's essentially opening it up and allowing it all to drain out and everything. For recurrent abscesses or excuse me, recurrent urinary tract infections in men.
So post cultures. So after you treat somebody, do you need to get a urine culture? No. If their symptoms are resolved, that bacteria, that E. coli that just caused that infection, you might not sterilize your bladder. It might still hang out, but now they're friendly and they're not causing any harm. So it's really impossible to sterilize things once they kind of get, colonized in certain patients. So it's not necessary to repeat culture, and you don't need test and cure.
Right, and this is a common question where someone will say, well, how do I know it's gone? And usually I'll ask them, well, are you feeling any symptoms? And if they say no, then that's the goal. Right?
Yes.
That's the whole reason. So if they're not feeling any symptoms, there would be no reason to go back and test them again. And then if you did test them and that it grew something, then that would be asymptomatic bacteria. And so wouldn't need to treat anyway. So test of cure, not needed unless they're having symptoms or it's continuing to go on for some reason.
Yeah, so recurrent UTI is defined as 2 or more infection in 6 months period, or 3 or more culture proven infections in 12 months period. So this happens sometimes. A female can have a friendly E. coli. 2 months later, they usually have the same bacteria, but it will be more resistant. So recurrent UTI we see a lot. Mm-hmm. The question we always get asked is, should we put this patient on antibiotics forever? So we do see this happen a lot, but we don't put patients on suppressive antibiotic therapy. Occasionally, you could give antibiotic low dose post-coital if you have a young female who keeps on getting UTI after sexual intercourse. You could give some post-coital, but otherwise, we really don't do a lot of chronic suppression.
Right, and the longer you're on antibiotics, the more you get the side effects and the adverse events, and the benefits decrease. So the benefits decrease and the adverse events increase. And so we do everything we can not to put someone on chronic antibiotics forever.
Especially in our elderly patients, like if you put them on chronic antibiotics, the bacteria gets more and more resistant. Mm-hmm. And now we have destroyed their good colon flora. Now they're at high risk for C. diff. Once you're over 65 and you get C. diff, your mortality can be up to 50%. So there's a lot of downstream effects. Mm-hmm. So I think we just have to be really careful.
And for some antibiotics, people are wondering, does this get good concentrations in the bladder? And for that, if you look at Sanford Guide about how it leaves the body, a lot of the antibiotics leave the body through the urinary system. So beta-lactams will actually concentrate in the bladder. So so that's one way to tell that you're getting good levels in the bladder. And pyelonephritis, signs and symptoms. So localized flank pain. So if you push, on the CVA tenderness is what we call it, to see if they're tender on their flanks. If they're tender in the flanks, if they have a fever and dysuria and things, then we'll wonder about, does this person have pyelo? Low back pain. So sometimes people will say, I have low back pain, or and it's good to kind of classify that in your mind as, is this new or is this old, and where is it located? Is it in the center back on their spine, or is it on the sides? Is it really CVA tenderness from their kidneys? Abdominal pain. So, and this is like low back pain. So where is the abdominal pain? Is it more over the bladder, or is it in a different region? Fevers, rigors, night sweats, headache, nausea, vomiting, malaise. So when it comes to bacteria in the blood, so when it comes to bacteremia, usually the buzzword is chills. The person says, they're coming in with kind of low back pain and chills, and I'll start to wonder, do they have pyelonephritis? Would you?
Yeah. And then you worry about bacteremia, sepsis, and usually that's how it's important to treat early. You get sometimes nausea, vomiting, weakness, headaches, malaise, but I think the other symptoms are more important. And I also like to emphasize that costovertebral angle pain, kind of up here, right below your rib cages in the back. That's where, like, if you tap, that's where you're going to get the pain a lot of time, where your kidneys are behind there.
And a wide variation in severity. Mild pyelonephritis may mimic cystitis. So it's not always clear if they have pyelo or just a straight cystitis, but if they're having fevers or they look sick in any way, I immediately think this is going to be pyelo and not just a simple cystitis.
Agreed. And there's rare cases where you get abscesses and septic shock. Well, I think we see a lot of septic shock with your urosepsis, so it's not as rare. We see more and more of that, and I think that's why it's important to treat aggressively up front. One thing we could also talk about here is if you're thinking about somebody's having sepsis of urological origin, a lot of times you don't need to do the vancomycin combo because we know it's like, unless they have history of gram-positive bacteria, you could do just gram-negatives too, so that you remember, like ceftriaxone, cefepime, something that'll cover the urological bugs.
And as far as abscesses go, one common question we get is, does this abscess need to be drained? And a lot of that, really, abscesses, no matter where they are, ideally you would have them drained.
Yeah.
And sometimes it relates to the size of the abscess. But one good way to get it drained is to ask interventional radiology if they can put a needle into it and then drain it, either aspirate it or drain it that way. Anytime interventional radiology says they'll aspirate something or drain something, I support that.
Yes.
I told our interventional radiologist that the other day. I like giving them as much work as we can.
And the other thing to remember about renal abscesses, if that is present, you have to treat for a longer time, like 3 to 4 weeks. And you also should get imaging before you stop the antibiotic, because sometimes it can't come back again. So it's, renal infections, especially abscesses, can get really bad to the point where you have to take out a kidney.
Yeah.
So it's really important to drain, treat long time, and re-image to make sure it's gone.
Yeah, and generally when people ask me about an abscess, no matter where the location is, whether it's the kidneys or the liver or where, they'll say, how long should we treat for this? And really the most important thing is what you just said. Yeah. It's re-imaging to ensure resolution. So instead of saying, for an abscess, I always treat this long, but I do the exact same thing. I'll treat for 3 weeks and then re-image. And I would keep them on antibiotics until you re-image. So you're not changing too many variables at one time. You keep them on antibiotics, you re-image and see where you're at. And is it getting bigger? Is it getting smaller? Is it going away? If interventional radiology was able to get a good culture of it, and you're treating it appropriately, and it hasn't, if you're treating it appropriately, then it really should be improving. If it's not improving and you weren't able to get a culture of it, or nothing grew from the urine that you can implicate, then it would be more of a time to push again for getting drainage of it and getting a good culture so you know what you're treating and can get at it appropriately. And that would also make sure you're not, trying to treat an ESBO with ceftriaxone.
Yeah, like exactly. I was just thinking that if people are not improving, like you might.
Yeah, I need to escalate antibiotics or something. You're
giving the wrong therapy for the bug. And then, something to think about, when is it uncomplicated? Can you treat outpatient versus inpatient? So, I think mild infection, if they could take oral, you could try oral before you try to admit them.
Yeah, and no vomiting. So if they're able to take down their pills, if they're vomiting and they can't take the antibiotics, then they would need to be. Yeah.
Yeah.
Oh, and this is this is emphasizing the vomiting. So if a person can't get their antibiotics, then they're going to continue to fail until you can somehow get your antibiotics into their bloodstream.
Hypotensive, kidney stones, renal abscess, pregnant females, if they're not doing well, all of them should consider admitting, starting IV, and then you could step down to oral when they're better.
Yeah, and due to the high incidence of resistance to fluoroquinolones in our area, if someone gets admitted to the hospital and you don't have the organism, I would choose something more along the lines of Zosyn or ceftriaxone or something instead of a fluoroquinolone. So if they're worsening on a PO fluoroquinolone before coming in, then I wouldn't continue a fluoroquinolone.
Yeah, that's a really good point. My rule of thumb is if somebody's sick enough to get admitted to the hospital with urinary tract infection, I don't give Bactrim or fluoroquinolone because the resistance is so high. I do like ceftriaxone or something along those lines. And then once you know the susceptibility, you could always step down.
Let's see, treatment of severe infection. So hospitalized, urine gram stain, and this is what we were just saying, I think. Third generation cephalosporin, aztreonam, gentamicin.
If you're worried about a gram-positive, you could do ampicillin ovunco and Enterococcus, stuff. But for most part, it's gram-negative. So our cephalosporin third generation ceftriaxone would be great.
Yes. So even if they have a penicillin allergy, if they're okay taking cephalosporins, if they can't take Zosyn, then you want to give cephalosporins, or there's still other options here.
The duration of treatment, so for just cystitis, how long do we treat? For the most part, just 3 days. So you have a female who has cystitis, no other complication, 3-day regimen is plenty to treat that cystitis.
And this is often when we get questions in the hospital with hospitalized patients, if they're already getting treated for, say, a pneumonia, and they're saying, well, I think they have a urinary tract infection as well. We can look at it and say, well, they've already received more than 3 days of antibiotics, so consider it treated. So,
and here's some buzzword like acute cystitis, recurrent cystitis. 3 days is fine. Pyelo, 14 days. Sometimes now we do 10 to 14. More and more we're coming lower on the days. A complicated UTI, for example, like a pregnant female, you might do that for 7 days to treat them. I wanted to kind of point here. So, here's the antibiogram. All of us have antibiogram, and it's a cheat sheet. So it's really important to use this when you guys have your antibiogram. So if you look at the E. coli, for example, if you look at the ceftriaxone here, it's 94% susceptible, right? But if you look at your Cipro is 77, your Levo is 78.
Right, so that means only 78% of the time would the levofloxacin work.
And your Bactrim over here, and we'll see, the Bactrim over here is 73%. So this is why it's really important that empirically when we're treating, that we look at our antibiogram and make sure that we're picking the right kind. So it's a really nice cheat sheet if you're using the antibiogram and making sure that we pick the right therapy when people are really sick and in the hospital.
So with these antibiograms, they'll check within our hospital system all of the E. coli that grew, and you can see here there are 9,605 E. coli that grew in culture that were tested, and then what percent of them are susceptible to the antibiotic. And so if it's something low, like 77%, so Cipro only works 77% of the time for E. coli in our system, and that's not very good.
Yeah, and then I look at what I want to give is something over 90%. And then I look at so if I do Zosyn, for example, right, we're covering for Pseudomonas, we're covering for anaerobes. So can I still make it a little bit less broad? So that's why when I come to ceftriaxone, it's still 94%, but you made it a little bit not so broader. So, in an elderly patient, you're not causing C. diff. So I think it's really important tool that we all should be using. And a good rule of thumb is if preemptively when you're treating more than 90% susceptibility, you could pick one of those drugs.
Yep.
So for Pyelo, how long do you duration of treatment? About 2 weeks. And here we have asymptomatic bacteriuria. So it's interesting, right? If you guys look at it, if you're less than 65 years of age versus older, when you're younger, 5% coloni asymptomatic bacteria in females. Males, it's really low when you're younger. But as we get older, in males and females, the asymptomatic bacteria numbers go up pretty high.
Asymptomatic bacteria, general indications for treatment, not indicated for chronic indwelling urinary catheter. So all of those patients with Foley's will grow something, but it doesn't mean it needs treatment. Indicated for increased risk of reflux, so pregnancy, renal transplants, pre-op, urological surgery. So with pregnancy, and this was covered earlier. So pregnancy, you treat because the baby can come early and be low birth weight, and then they have a higher incidence of getting pyelo for urinary tract, any kind of growth in the urine.
Yeah. I think there are three things to take away for all of us is that when do we treat when they don't have any symptoms, but we find the bacteria in the urine? If they're pregnant, if they just had a kidney transplant about after 6 months, and then also urological procedure. So, you found E. coli, they're going to have a cystoscopy and they're going to place a stent. You're manipulating that area. And I like what Dr. Hong always says, that when you're doing that, you're putting a lot of pressure and water, and you could have like transiently this bacteria in your bladder go into the blood. So in those cases, you could treat asymptomatic bacteria. 3 things: pregnancy, renal transplant, pre-op urological surgery.
And with the pre-op urological surgery, it's just a 1 dose before the procedure.
Yeah.
So you don't need to treat, the week before or anything like that. It's just a one-time dose. So you have good blood levels at the time of the procedure.
We always get asked this thing too. This patient's having a hip surgery, shoulder surgery, knee surgery. Now, any of those does not need urine culture or urine analysis and treating the urine because they're not doing any urinary tract surgeries.
Yeah, the surgery, I went to one of our partners the other day and I said, our patient's having a neurological surgery and the neurosurgeon wants to give treatment for their asymptomatic bacteriuria. And I said, it's kind of odd because the surgery is up here, and he said, yeah, it sounds like they don't know their head from their, and I said, okay. I don't quite put it that way, but that's one way you can help remember. The UTI in men, so the pathophysiology.
Usually, I think of it as like, males is protective because the urethra is longer, but then they get infection when there's structural issues, like you were talking
like
about
prostate and foreign bodies. So these are like foreign bodies, like stones and things like that.
Yeah.
Yep.
And again, in the males, pretty similar, like females, dysuria, frequency, urgency, and there's other symptoms, but these 3 are the top 3, I would say. And also think about like STIs in males as well.
Then in cultures, so this is kind of the same thing where if they're a high culture count, it'll help support it, but doesn't necessarily need it. The most important thing are symptoms. And then in men, you have mostly gram-negative rods. You have some gram-positive cocci. And then acute cystitis treatment. So you want to treat a bit longer in men than you would for, because all men would be considered complicated.
It's about 7 days.
Yep. And then with recurrent infection, so less than a month after completing therapy that reoccurs, then you can treat for 7 days, but you also think about why is this reoccurring? Right, and then start looking for reasons.
Urinary prevention, how do we prevent it? Urinate after sexual activity, hydration, certain things that they give some information on CDC.
And as far as prostatitis, there's acute prostatitis or chronic prostatitis. With prostatitis, generally people talk about giving either Bactrim or fluoroquinolones as far as antibiotics that get good penetration into the prostate. But prolonged courses, so sometimes they'll talk about 4 to 6 weeks.
Yeah.
Generally, I think people treat around 4 weeks or so.
4 weeks. If it's not Bactrim or quinolones, then you're kind of stuck with antibiotic, unfortunately.
And then there are non-bacterial causes of prostatitis.
Trauma, and other viral infections, even drugs. So kind of important to keep in mind what they're taking.
And then here's a good lecture summary. And we do have a few questions. We might go through these kind of quickly here just to, looks like we're just about out of time, but we can quickly discuss these. The first question is, which one of these patients does not need treatment for asymptomatic bacteria? And the first one's a pregnant patient. The second one is a 95-year-old female from a nursing home getting admitted for pneumonia, and bacteria is seen on their urine analysis. And then C is a 45-year-old male scheduled to have a cystoscopy. Does anyone have any guesses? Okay, so we talked about earlier that the answer here is B. So they do not need treatment. So a pregnant patient would need treatment, and a person in C is before a urological procedure. And then here's the next question. This is a 54-year-old woman presented 1 week with urinary frequency, urgency, dysuria. You treated her with Bactrim for 3 days. Her symptoms resolved after treatment. She calls you today, says that she no longer has symptoms, but would like to get a urine culture to make sure. What is the next step?
I had 3 days of Bactrim, I had 3 days of legal reassurance, urine analysis, culture now.
Right, so she was treated appropriately for 3 days.
And no symptoms, so you would just reassure.
Right, so she's asking for a test of cure, and you can tell her, you don't have any symptoms, so I think you're good. And this is a 74-year-old woman with recurrent cystitis. She has received 4 successful treatments with nitropyrantoin in the past year. She says that her best friend in the nursing home has been on daily nitropyrantoin for several years to prevent cystitis, and asks if you can take nitropyrantoin daily like her friend does. So what do you recommend? Do you recommend nitropyrantoin chronic daily prophylaxis, levofloxacin chronic daily prophylaxis, Bactrim chronic daily prophylaxis, cycling antibiotics? So this is the kind of the process of giving one antibiotic for a week, another antibiotic for a week, and kind of cycling through, or culturing the urine when symptomatic and treating them.
I'm gonna go with culturing only when
Yes.
symptomatic.
Right. So, and this is a good stewardship question. So it's trying to make sure that we only give antibiotics when necessary, in the right duration and dose and everything. So yeah, we don't recommend cycling antibiotics. We have seen people do that, but as much as possible, I recommend not doing that.
This question is a 64-year-old patient presents with fever. You are rotating on the infectious disease service, and you're asked to see the patient 3 days into the hospital stay. You are asked to see the patient because clean catch midstream urine specimen was collected and it's going MRSA. Blood cultures haven't been ordered yet. You examine the patient and hear new heart murmur. So the patient says he doesn't have any urinary tract symptoms. So what should you tell him? So here is when you have to kind of start thinking, like we talked about earlier, MRSAs are not a common MRSA, MS is a urine flora. So you usually have to think about it came to the blood, to the urine. So one of the suspicions should be with a new murmur, think about endocarditis.
Yes, and that's the answer. So this is, I would think, about a harder question than the others, because you have to put together that, just as you said, Staph aureus is not common. They have a fever, which wouldn't be common with the UTI. Then they have a new murmur. So, and we've seen, patients where they consult us for a urinary tract infection, and it turns out to be Staph aureus endocarditis. And then there's this question: 57-year-old man presents for a scheduled cystoscopy for hematuria. Last week, he had a urine culture which grew E. coli. He has no urinary symptoms. You tell him he will only receive 1 dose of an antibiotic before his procedure. He asks, why will I only get 1 dose? Don't I need several days of an antibiotic to get rid of a UTI? And what do you tell him? You tell him, A, we will repeat a urine culture to make sure your bladder is sterile. B, you have a silent UTI, which doesn't need much treatment. C, we aren't trying to sterilize the bladder. We're trying to prevent bacteremia. Or D, you have prostatitis, and you'll need a longer treatment.
In this case, we're just trying to prevent bacteremia during the procedure.
Right. So, he may have asymptomatic bacteria, which is what he has. And you're not trying to treat him to get rid of it. You're just trying to keep it out of the blood when he has his procedure, which can cause cuts under high pressure and push kind of bacteria into the blood. So I hope that was helpful. I think we covered a lot.
Yeah, we covered a lot. Hope that was helpful, and please let us know if you guys have any questions or concerns. And then will you also email us and let us know if you would like an update on COVID-19? We're happy to do that as well. Any questions today at all? Well,
All right, well, thank you very much for joining us.
and we will forward the video and the slides. Thank you so much.